A very good morning to all of you. I'm Dr. Manazia from Department of Anesthesiology. Today I'm going to discuss rush protocol, that is rapid ultrasound for shock and hypotension. As you know, the assessment of shock and hypotension is very important in its management. We know there are a variety of shocks like hypovolemic, distributive, anaphylactic, cardiogenic shock. Each and every shock has different etiopathogenesis and different management. To differentiate among these various types of shock, ultrasonography can be very useful in these conditions. So it is said that you have to use probe to scan pipes, pumps and tank. As you know, ultrasound is a very rapid technique, hardly takes few minutes. It's very easy to perform and the learning curve is very less. Coming to the basic requirements, the two most important probes which you require for a USG guided rush protocol is the phased array probe, that is of 3.5 to 5 megahertz, and a linear probe of 7.5 to 10 megahertz. The frequency of these probes are very important because the lesser is the frequency, the more is the penetration and the depth, the organs which can you can see, and the lesser is the frequency, the more superficial. The higher the frequency, the more superficial structure you will be able to see. Coming to the components, there are mainly three components in rush protocol, that is pump, tank and the pipes. The pump is basically the heart and the tanks are basically the intravascular compartment, and when the pipes are the large arteries and veins. You can remember these components by a mnemonic HIMAP in which H stands for the heart, I for the inferior vena cava, M for the Morrison's or fast abdominal views, A for aorta and P for pneumothorax. Coming to the various components which you have to check for, the first and foremost is when you're looking for the heart, then you have to look for the tamponade. Are there any kind of fluid collection in the pericardial space? Whether the left ventricular function is good, adequate or not, whether the RV function is adequate or not. So these are the three things which you have to look for when you are assessing the heart. The next important component is in the intravascular compartment. Here you have to look for the inferior vena cava. You have to look for the diameter of the inferior vena cava, whether it is full or not full. And what is the collapsibility? Collapsibility is the thing, how much percentage of the diameter is collapsed during respiratory variation or respiratory cycle. So you can use the M mode of the ultrasonography to assess the various collapsibility basis of IVC. Next important thing under the intravascular tanks is thoracic and abdominal fast, which I will discuss in the next slide. And the last one is the pipes or large arteries. Under these comes the aorta, femoral and popliteal veins. Coming to the sequence of the rush examination, the first and foremost is the pump. It is examined under two views, the para-external long axis view or called as flax view and apical four-chamber view. This is a picture showing the para-external long axis view of the normal heart. Here you can see the LA, left atrium, is the LV. This is the left ventricular outflow tract, which is the aortic wall, and this small chamber is the right ventricle. This is the situation, or this is the view which a normal heart would look like. But if you have the cardiomegaly or right ventricular enlargement, you would see a left ventricular compression with a large right ventricle. The grossly enlarged right ventricular stain is a feature of right ventricular stain. You can also find septum which is deviated toward the LV. Second important thing which you can find is you can also look here. This black shadow is a descending thoracic aorta. If you find any kind of fluid collection here, there is a white line normally in the pericardium, which is Chinese structure. If you find any kind of fluid here, then it is called as pericardial effusion or tamponade, depending on the clinical diagnosis. Next important view is the apical four-chamber view, under which you can see all the chambers of the heart, that is RA, RV, LA and LV. You can have a gross assessment of the ventricular and contractility, that is RV or LV. You can also find either any kind of fluid collection is there or not. The third most important component is the inferior vena cava assessment. Here you have to put your linear probe here in the longitudinal section or you can sagittal section and look for the diameter as well as collapsibility. If you see here, this is the inferior vena cava, which is a dilated and non-collapsible structure. So this patient does not require any kind of further fluid. While this IVC in contrast is a collapsed IVC and it may show collapsibility with variation of the respiratory cycle. Next important are the components of the fast, that is we have to look for the hepatorenal pouch, splenorenal pouch, bladder or pelvic examination view, and aortic views like suprarenal and infrarenal views. The last and the not least is the pneumothorax assessment. You have to look for because the anterior chest wall in the mid-clavicular line in patient when the patient is in the supine position. As air goes up, so this is the best view to assess the pneumothorax in supine position. Coming to how to examine the hepatorenal pouch, there are four things which you have to look for the hepatorenal pouch. That is the right corsophrenic rhesus. Here you can look for any kind of fluid collection in the form of pleural effusion. The subdiaphragmatic space is assessed for any kind of fluid collection here. Hepatorenal rhesus and inferior colorectal should be looked for any kind of fluid collection, whether it can be blood or any kind of fluid leakage. So these are the four areas which you have to look for. Next important thing is the splenorenal pouch. Here again you have to look for all the four areas which I have discussed, the hepatorenal area, hepatorenal pouch in the previous slide. So all those areas have to be again assessed whether there is any kind of fluid collection or not. And the last area is the tank or pelvis area, in which there is a bladder, uterus, and a rectouterine pouch. If you see any kind of correction here in the rectouterine area, it suggests any kind of disruption of the any kind of vista here. This is the chest, which is shown in the V mode. Here you can see two ribs, here one and here two, with a shiny shimmering white line, which is called as pleural sliding. So this, if you can find this pleural sliding, then it obviates the presence of any kind of pneumothorax. This typical appearance is also called as battening sign, and if you see this thing in M mode, what you will find is the seashore sign. If there is a loss of the seashore sign, it suggests there the presence of pneumothorax. Coming to the pipes, here you have to assess the aorta. The four areas of the aorta which you have to assess are the aortic arch in the suprasternal area, the suprarenal abdominal aorta where you can find the celiac trunk with Siegel sign, and infrarenal abdominal aorta where you can find the portal conference, superior mesenteric artery, and left renal vein. If you go down, what you will find is the aortic bifurcation and into right and left common iliac arteries. So in summary, you can have three things: pump, tanks, and pipes, on the basis of which you can differentiate the basis of hypovolemic shock, distributive shock, obstetric shock, and cardiogenic shock. In hypovolemic shock, there will be hyperdynamic heart with a small collapsing IVC. There may be a collection of the peritoneal or pleural fluid with aortic or dissection, presence or absence of aortic dissection. In distributive shock of the early sepsis, there will be hyperdynamic heart, but in the late stages of the sepsis, there will be myocardial depression and poor conductivity will be seen. There may be normal small IVC. There can be collection of pleural or peritoneal fluid with normal areas of the vessels, great large vessels. In obstetric shock, they will like such as pericardial tamponade, you will find the features of right ventricular strain, which I have discussed in the previous slide. There will be poor conductivity. The large and non-collapsing IVC would be may be seen. Absent lung sliding sign, which I have discussed in the case of pneumothorax, and you may also find deep vein thrombosis features in the popliteal and femoral veins. In cardiogenic shock, there will be poor contractility, large non-collapsing IVC with features of pulmonary edema in the form of lung rockets. You may also find pleural effusion with normal pipes. Thank you.